to the station tubes. But it's not always present in all the cases. These are the tests which were used earlier, but there's a problem. The patients are having they have perforation in the tympanometery. We cannot perform a tympanometry. We cannot rely on them. And for patients who have pasterization tube, then even the scores will not be actually be collaborative. In patients who are barrow challenged, these are the patients who normally will have a good gestation tube function, but they're barrow challenged, probably they're taking a flight or they're scuba diving, they will have a problem. So I will tell when they will have a problem, why they will have a problem. And then there is the ambient pressure tympanometry, which basically is a test which depends upon the sound being causing movement in the tympanometery. So not we are using. So a word about sonotrophometry basically is a test which is non-invasive, and basically sound is conducted from the nose into the gestation tube, and the patient are to make swallows and yawning and saliva is he made to do. And on that there is a resisted stimulus which goes to the gestation tube, and there is a movement of the tympanic membrane that is captured in the probe inside the gestation in the external auditory canal. And the graphs are plotted, and according to that some kind of results are produced. That's a flow chart. We are not following this, not even to manometry, but it's a very vital test being done in many centers in Europe, where they give a pressure of 30, 40, and 50 millibar through the nasal cavity into the nasopharynx, and the pressure probe in the auditory canal registers the pressure changes produced. So it's a complex test where an R value is calculated, and this R value is calculated according to this formula, where the P1 will represent the start of moving of the tympanic membrane, and P2 will be the C2 will be C1 will be the start of pressure increase in the nasopharynx, and C2 will be the maximum pressure increase in the nasopharynx. So this formula will give us R value. The R value is less than 1, it's a normal thing. R is more than 1, it's a restricted gestation function. And no opening, obviously, it's a negative response. So we are not following this. This is most important here. Any patient who comes to us first has a test of the drum, a tympanometery, and then a questionnaire. This questionnaire are basically, there are two types of questionnaires which are available. The first questionnaire, the DDQ score, is the most commonly used. This is the questionnaire, and the pressure, pain, the feeling of cloggedness, ear symptoms produced by cold, crackling sounds and popping sounds heard in the ear, ringing of the ear, and feeling that you are having a muffled sound in the ear. These are 7 parameters which are checked, and no problem, moderate problem, severe problem, and the scoring is given to each. So it's like this. Red is for the right ear and left is the that ear. So you calculate the score, add it up, and the score will tell you how much the problem is in this. And it's very collaborative. It has been seen the scores do not basically differentiate between the problem, which type it is, obstructive or patulous, but they do tell how much the problem is. These scores are high value in assessing the degree of problem, and they are extremely valuable in assessing the results. So I will leave this. So basically this is Dr. Dennis Poe, he is the pioneer who is working on gestation tube a very long time. So what he devised was the gestation tube endoscopy, and it's basically done by a nasopharyngeal scope which is 3.7 millimeters, or we can do with a direct endoscope of 3 or 4 millimeter size, which is angled at 30 or 40 degrees. So these are the parameters which are checked. Most important is check for the nose and the sinuses because they can be contributed to the problems in the gestation tube. Second is to check for the gestation tube orifice. Is it actually closed? Is it edematous? It is patent or patulous? So there is a check called the Melo check, which tells you about the mucosa, the erythema, the edema, the lymphoid hypertrophy, and the gestation tube opening. So these are 5 quick checks we have to do at the first step. Then we check for the adenoids because they are largely contributory to the gestation tube dysfunction. Then the torus itself can be quite thickened medially or laterally. So there can be a lateral thickening contributing to gestation tube dysfunction, and there can be a medial thickening which is not contributing at all. So we have to check on both the sides, the osment band fat thickness, and about the redundant mucosal bands, which is also called the Poe bands going along the floor of gestation tube. So there are certain movements which our patient is told to perform. There is ka, and then the patient asks to swallow, and then a yawn. So this is the fancy grading system we have devised because we don't have a tumor manometer. So it has a normal grading for these normal findings. They are mildly inflamed with the with a compromised valve opening. The valve is just slightly not compromised, not opening properly, and severe if there is severe opening of the valve. So if we see this is a video showing a normal station tube function. So that's the medial wall, that's the lateral wall, and you can appreciate the patient where the adenoid tissues are not there, and there is no inflammation. The station tube is closed. There is a curve which is happening, and the torus moving laterally. Then ask the patient to perform a swallow, and then you see the opening there. Right there, you see the opening up. That opening is happening just 0.4 seconds. You have to slow down the videos, record the videos, and see it again. Sometimes there is a mismatch between the two. Both are contracting at the same time. So it has to be seen that way. So this is normal. I'll skip this. Okay. See this? There's a huge adenoid tissue, and there's a curve, and you see the torus moving forwards. So there's a paradoxical movement of the torus. Actually, it's not moving medially; it's coming forward. So hardly any opening occurring there. The patient once he swallows, nothing will be there, and you see a lot of cobblestoning of the walls of the torus. And there's quite a edema in the lateral wall going inside in the valve area. So this is a patient, ideal patient, which will probably require a tuboplasty. Okay. So this patient had a hypertrophy of the torus and went on into the ostia. So I didn't have. Did you fix the adenoid also? Yes, I will come. This is a similar video. I will skip this also. This is also a similar video. I will skip this. Okay. This is a patient having a problem with the function. Look at the problem line.
Now, Vikram, are you showing us the valve area also in some video?
Okay. So the valve area is there only. It's closed. I'm showing the pathologies right now. I showed the normal one in the first one. These are all pathologies. We will not be able to see the valve area because we're not reaching there. This patient has sinusitis and there was post-fluid drip, and this was the problem the patient was having. Actually, there was no other problem. The problem was with the sinuses. That's why I said it has to start with the sinuses and end with the laryngoscopy to check for the gastroesophageal flux. So these are two additional things you have to do. So these are the core bands which I was talking about. This is a patient with an obstructive barochallenge problem. You see a band which is going inside right there. Once this patient is barochallenged, he will have problems. So this is called a core band, we say, because after there is core. And these are the patients which can benefit largely by the tuboplasty. So that is the station tube score which was given earlier. And basically it tells you to swallow. Once you swallow, there is a clicking sound. We all have that. It's normal. And then you have to perform Valsalva and the Tympanometery scores. Tympanometery scores we are not doing. That's why we had modified into a MAMC score, which we had the station tube opening as the scores. So this is the MAMC scoring system. So it's a clicking sound, a Valsalva, and a grading of the station tube opening. The mild and severe. So there are points given to that. If the score is less than 3, that's an indicator for a bed. A balloon station tube, that's a tuboplasty. Right? So there are three types of pathologies you can offer: a bacillus, obstructive, and a barochallenge. So according to the definition, the obstructive type is that you cannot
Bacillus opening nose है
and especially if you're barochallenge.
opening है बड़ा हो गया.
So the patient which largely presents with fullness of the ear, ठीक है, कान भारी लगते हैं और बहुत सर्जरीज पहले हो चुकी हैं bromide insertions because we all have been treating them like this only earlier. The causes are these: adrenal hypertrophy, there is mucosal thickening because of upper respiratory tract infection, cleft palate, nervous diseases. There are various causes for this. So what you have to do is that you have to see for the retraction of the tympanic membrane. Ask the patient to perform Valsalva. They will be having a difficulty in doing that. You can have retraction pockets on a long-term basis, secretitis media, inflammation in the tympanic membrane, and tympanometery will definitely show the findings of retraction. Bacillus will have oral fullness, but there will be cracking and popping sounds, including the score. This included in the score that questionnaire. all patients will have a popping and cracking. So this occur because the station will be opening and closing on its own, just equalize or close. There is autophony. Obviously, it's open, and the sounds which are not supposed to go inside the ear, they're going inside. And it has to be differentiated from the superior semicircular dehiscence syndrome because there is a thing called a solid autophony, and there is a thing called a non-solid autophony. Patients with chronic allergic rhinitis, these are the major group of patients which will land up with eventually having a patch station tube. Initially, they will have an obstructive type, but after a few years, they will be having a patch station tube because the mucosa will atrophy on long-term follow-ups. And these will be having 40% of the patients with patch station tube will be having a chronic allergic rhinitis. And they also have some voice distortions. So, how do you can check it? You ask the patient to perform exercise. Patient will have dehydration, and there will be more of patency of these station. So there will be more of symptoms. Then ask the patient to put down the head inside between the knees. झुकने के बोलेंगे सर को knees के बीच में डालेंगे. Congestion होगा, station tube के आसपास भी congestion होगा, and the symptoms will retract. And patient will say, "I am feeling better. I am feeling better." So these are two tests you can perform in a patient who is telling you about a symptom, and you can confirm. And there is the thing called sniffers. Patients who are having patch station tube will try to control the symptoms. So they will sniff करेंगे ताकि negative pressure यहाँ create हो. And instead of having symptoms of bulging out the end, they will symptoms of retractions. So they will confuse you with the findings. And you ask them why you're sniffing, अच्छा लग रहा है, कान में अच्छा लग रहा है सुनना sniff करने से. So they are trying to equate they are trying to do a negative pressure inside the nasopharynx. Right? So, you do otoscopy for these patients and you see that the tympanic membrane will be moving. Especially, you exaggerate the findings, you close the contralateral side, ask the patient to sniff deep, and there will be a movement. अगर हल्का ऐसे मूव नहीं कर रहा है, तो आप contralateral side को nose को बंद करिए and you sniff, and then it will move very nicely. And same will be happening in a tympanometry. So you see a patient, you see this kind of situation, this is a worst situation it can occur, but you can have a situation where only this part is patchwork. You have to be very closely looking at it. Thing which is looking very close is not actually close. There is a patchwork tendency in the valve area right up there. You have to closely look at it. So I told you about the mobilities. Most is the allergies. Then sudden weight loss is certainly a factor. Then GRD and hepatitis media, hormone resistant therapies, smoking. So these all have been documented as factors for the pathology. So that's the algorithm for diagnosis. Please have a look at this. A retracted tympanic membrane, the tympanogram like this, symptoms like this of with station tube, endoscopy. Then there is a patient who has a normal tympanic membrane. This patient who has a negative pressure obviously is obstructive to station tube dysfunction. Then there can be a patient who has a barrow challenge. Normal tympanic membrane, obstructive dysfunction. Patient with autophonic, inappropriate sniffing, patch station tube. This is a patient with normal tympanic membrane, no autophonic, no barrow challenge, normal tympanic membrane, oral fullness hai. The problem is somewhere else. The problem is with migraine, tympanomandibular joint disorders, submental disorders, inner ear height loss. So you have to closely look at how you are looking at your patient. So there can be hypertrophy of the pterygoid muscle. You palpate deep inside, there will be hypertrophy. This has attachment to the station tube. The patient is having contractions and there is a patch station. So what do you do if the tympanic membrane is retracted and the station tube score is normal? There can be a blockage in the bony station tube. Here where the CT role of CT comes in. 10% of the problems are in the bony station tube. There we have to do a CT scan, have to rule out the problems in the station tube with the bony part. So this is the treatment protocol you have to follow. You ask the patient to do valve valve, intranasal steroid. Smoking definitely has to be stopped. GRD treatments and nasal allergy treatments. Ear poppers are available and they are very good. And they relieve symptoms in a lot of patients, especially children. They can be recommended. Then there is autovent, it's again available in India and available on Amazon. I found they have to be they are useful in a lot of patients. Then meningotomy can be an option, though this relief is very of short term basically. Then there can be a torus hypertrophy, and you can reduce the torus. This kind of a torus will not respond to a balloon dilatation. You have to take an incision, take out the extra tissue from there, and then probably put a suture there. It's difficult, but it's feasible. As I said, adenectomy is an important thing to be done. So we do a partial adenectomy, a lateral adenectomy is done, because that lateral adenectomy will be like 2 millimeter tissue around the eustachian tube opening, which is causing the problem. So the protocol these days is to do a lateral adenectomy bilaterally. So सारा इसलिए नहीं निकालना है कि immunity maintain रहेगा. And that is minimal invasive technique. This is a balloon plastic technique. Minimal invasive technique with very good results. And when to do is important. This is the crux of the talk I want to emphasize. You have to score your patients, have the ET scores done, and the indication then follows. Once you have diagnosed, this should be the thing. And I will tell you how to go about it. I'll just leave it for time being. It's under general anesthesia we do it. The pressure inside is 10 to 12 bars. Time duration of dilation is maximum is 2 minutes. For children is 90 seconds. Because we land up with patulation tubes, we do it for longer time. Bed has a long-term good effect. It has been seen. Cadaveric studies, even 2 years, 3 years hence the time, they have shown a good function of the procedure. These are the things used in the fluoplasty. There are two companies basically doing it. One is from Merrill and this regular system. They are slightly different from each other. So I'm not going to this small video, just showing how the thing is done. It's a very simple procedure. Thing only is that you should know when to do it, and these are the patients who will benefit from it. The catheter is passed in eustachian tube without any trauma. You pass in the balloon now that the balloon is coming in now, and it is reduced till a certain mark, which is a black mark. It's just not visible here. Okay, and then you dilate the balloon. It has a tendency to come back once you're dilating. So you have to hold on to the catheter. You see the balloon getting dilated inside, and you have to stay there for some time, as we have planned, like 90 seconds or 2 minutes, depending upon the eustachian tube score. And there's a line which is actually calling that it to expand. Normal thing, nothing special about it, but you just have to be atraumatic and not go inside too much. And it works like perfect in most of the patients. I will just show, I will skip this, there's another video, I'll skip this also. So complications can be patulation tube, unинdicated, extra time patulation tube. Bleeding problems can be there. They can be a perforation. I have not encountered these problems, but these are mentioned in the literature. This is how we do it actually. That's the score we take for all the patients. That's the PTA, audiogram, then the Tympanometery, and then finding out the panic memory. This is the score, the right being normal, left is abnormal. So the score is more than 20, indication for the toplasty to happen. And the second patient scores 35, 36, both the sides, EP gap is there, the B type is there. And after this, doing this, the procedure, it has decreased, not completely reverted though. So we have to see after sometimes like 3 months down the thing, we have done that. We have to assess till 6 months time. So there are things called laser tuboplasty, which is being done right now to decrease the size of the torus. We are not using, or I don't have any experience with this. So basically, the treatment for the passive eustachian tube is largely medical, but yeah, there are surgical treatments which are complicated, and it's very important to understand the patients are troubled, and we have to give relief to these patients. The most important is have a hypertonic saline solution. It works like magic, and how to do it is like you have to ask the patient to turn the head ipsilaterally 15 degrees and then 45 degrees backwards. Oh, sorry, 15 degrees backwards and 45 degrees this way. And he has to put the drops lying down and has to strike the eustachian tube opening. How do you know? the moment it strikes, the patient will have a tinge going towards the ear. It's called a twinge. It goes towards the ear. That's the time you're hit. And the patients know, after 3-4 attempts, know they have hit the station tube. And the relief is like for 8 to 12 hours. And patients suddenly very relieved. Then there is a roll of Petulant. It's widely available in US. I don't know, it's not available in India, I know. It's very effective. These are drops which are put in the nasal cavity, and they reverse they regenerate the mucosa in the patulous part of the station tube. So it has found to be beneficial in many cases. If the patients are not responding, a meningotomy can be a procedure which can be done. Just put in the abdomen and stays there. Patient is relieved for symptoms for a few months. Then cartilage tympanoplasty, definitely you are making the tympanometery heavy, but it's not actually a thing which will cure the symptoms completely. This is important, but this is what is happening as a research. There's a thing called a shim. I will show you what's a shim. So this is a thing which has a semi-solid rubberized endocatheter and which has a molten wax, and they put it inside the station tube and check it from the ear end. That it has come from the ear end just inside the protympanum. So this will basically obliterate most part of the station tube and make it largely competent. So this has been found to be quite effective. So universally, presently there are no universally